does help a little bit if the child has antibodies coming from the mother. But otherwise, children are pretty, they're likely hosts just because of their age and their prior exposure. And so we put them in the classroom with daycare providers who, unless they started out their careers in pre-med or nursing, may not know very much about how diseases are spread. And quite frankly, we may feel a little bit intimidated about this topic, but we just need to keep in mind that there are certain ways to cut down on the transmission of infectious disease, and we'll look at those in just a minute. But right now, I want to just sort of remind you that child care providers they are trusting parents to make a decision for the most part whether the child is healthy enough to attend child care. And frequently parents, they're thinking they don't want to use their vacation time to stay home with the kids. They want to use that for fun, fun activities with their children. And so frequently, without really meaning to do this, they dose them up with Tylenol and send them on their way. They don't understand that a temperature may be more of a symptom of an illness rather than an illness, and it's not making them better by giving them Tylenol. It's just reducing the fever. And so we have to keep this in mind. Parents want what's best for their child, of course, and we need to always keep that in mind. But they frequently do bring them to child care when they should probably be at home, and we'll talk a little bit about how to address that situation in a little while. So when you're looking at the spread of infectious disease, what you need to keep in mind is you have to start with a source, someone who is sick, and that person is going to spread germs, transmit those germs from one person to another in some way. And in child care, this is transmitted to children that are not sick. And there are 4 routes of transmission, ways that children become sick. The first being respiratory, and the way that is transmitted is a child would either cough or sneeze or talk, and those droplets would be airborne, and then they would either fall on another child. It would either be taken in, say, on a toy, or those respiratory illnesses that are spread in the air is what we're talking about. And they land on surfaces and can reinfect other children. They also land on other children, and they breathe them into their lungs. And these are the illnesses that are spread like this are things like flu and whooping cough, pertussis, RSV, strep, rubella. Those are all illnesses that are spread for the most part by respiratory route. And then the second route of transmission is fecal-oral, and those illnesses are very, very serious illnesses, the ones that often we hear about in the news. Things like Shigella, rotavirus, E. coli, Salmonella. Those are illnesses that are spread by fecal-oral, where fecal material gets on the hands of a child, and then they put their hand in their mouth, or they put toys that are contaminated with fecal feces, and then that goes in the mouth. And that's the second route of transmission. And then the third route of transmission is direct contact, and things like impetigo and ringworm, even lice and pinworms are spread by direct contact. Scabies, some things that are scabies is actually a mite, but it is still transmitted by direct contact. Ringworm is a fungus, but it's transmitted by direct contact or touching things that are. It also can be transmitted by things that are contaminated with like a towel or something. Sometimes also can transmit things that are often transmitted by direct contact. Then the fourth route of transmission is body fluids, and this is how hepatitis and HIV are spread. Things that have urine or vomit and blood contaminated can transmit illnesses by bloodborne illnesses. So now what I'd like to do is I'd like to look at several different types of illnesses, some which are a little more common in child care than others, but I wanted you to be able to, when you're in a daycare center and you're talking to providers about illnesses, if they brought you a child and you saw something like this, I would like you to be able to say, wow, this child probably should not be in the center because he may have something that's infectious. And the first one is chickenpox, varicella zoster, illness of chickenpox is spread by respiratory. Children cough and sneeze on other children, and that's how you spread chickenpox. There is a shot for chickenpox now, but it does not keep all children from getting chickenpox. So we still do see cases of chickenpox in child care. And it also can be spread by contact, by direct contact. So children who have chickenpox should be excluded from the child care center. It's highly contagious until they have a doctor's note and they're safe to return to care. Now, shingles is like the chickenpox virus, is caused by the same virus, but what happens is the virus lays latent in the nerve endings in the body, and at some point later when the body is compromised by either illness or stress, these shingles can come out, and it will be at the end of the nerve ending. You'll see it'll break out along the nerve and at the end, and it sort of looks like this. We're seeing a lot more kids with shingles than ever before. It's kind of interesting, and this used to be something you only thought about seeing in the elderly or older folks, but we're seeing more children with shingles. And this does require a doctor's note as well for them to return to care. Roseola, or 3-day measles, also spread by respiratory route. And unfortunately, the child usually has the fever and feeling kind of yucky, and we don't really know they have roseola until they get the rash, and the rash is kind of the end of the illness. Usually they've already spread it to other children before we see the rash, but I have seen several children over the years with roseola and child care. Pink eye is also something that's very common, conjunctivitis. It is spread by respiratory, also can be spread by towels and things that are infected, so that's direct or indirect. It can be viral or bacterial, and if you have someone who has had this in a family, sometimes you can see that this spreads very quickly through families, and if a child has a family member who has had pink eye, you can see how that would be easily transmitted from towels and things in the bathroom. This is strep throat. This is also a direct or indirect transmission, and it also can be transmitted by respiratory. The interesting thing about strep throat is that we usually see fever, but sometimes there isn't a fever. I've seen some pretty rotten-looking throats without a fever. They usually have swollen glands and tonsils and pus pockets that look sort of like this, but it does smell kind of sweet, and some folks, if you have a really sensitive nose, you can sometimes pick up on this just by holding a child and smelling their breath. It smells kind of sweet. But it is a bacterial infection. When sometimes strep throat can get very, very serious, and when it does, it often causes a rash that looks like this. It's a very fine pinpoint rash. I sort of think of this sort of infection, strep infection, as being strep gone viral, because it is a much more serious illness, and often these children are very, very sick with a high fever. They get scarlet fever. It's much more serious. Then this we see very, very often in child care with very young children. This disease is parvovirus, and parvovirus actually is transmitted by respiratory. We sometimes refer to this as slap cheek disease because it does cause a very, very bright red cheeks as the last part of the illness. Here again, usually children have already exposed other children to this by the time we figure out they have this, because the bright red cheeks don't usually occur until late in the illness. This is MRSA. It's methicillin-resistant Staphylococcus aureus. This isn't something we see this bad in child care, but staph infections are not that rare. Staph and strep can be carried and remain on surfaces for long periods of time. So this is a possibility. I mean, it is possible to get a staph infection. It is a bacterial infection. It is transmitted by touch or by objects that are infected with this bacterial infection. The bad thing about MRSA is that sometimes, well, it can get into joints and areas of the body and wall itself off, like in this child's knee. And it's very, very difficult to treat. And it can be transmitted from person to person in linen and on surfaces like toilets and things as well. So it's a very serious bacterial infection that is spread by direct contact. Thrush is very common in child care. We see children, usually what you see here is a yeast infection on the tongue, kind of a white coating on the tongue. We often see this also as in the form of a diaper rash. It's the same sort of infection, that yeast infection that causes a fungal infection. You can have it in the nail bed. It can be. It can also be. Yeast infections can occur other places on the body, like diaper rashes. And this tends to come out after a child has been, on a medication, or also stress can cause the good balance of bacterial balance in the gut to be out of whack. And then what happens after a child has been on an antibiotic or been through a stressful situation sometimes will come out as a yeast infection and have to be treated. This spreads through infant rooms very quickly because it can be through shared toys or pacifiers. It can spread it from one child to another. Impetigo is a very common illness. You often see this in child care on the face, under the nose, and around the mouth. It is spread by direct contact. I call this the kissing disease because if one child has it and they, above the mouth, and they kiss someone else, they can be spread by direct contact. It also can be spread by clothing and towels and things. But very, very common in child care. I've seen quite a few children with this. And it's very common from this time of year through the winter, because children will have a runny nose and gets sort of the skin kind of gets compromised above the mouth there, and it will break out, and this strep will infect the area of skin that's compromised, and they'll get an impetigo infection. This also is very common in child care, hand, foot, and mouth disease. It's the Coxsackie virus. I've had several children, or at least two, over the years that a child care provider brought me a child and showed me their feet, and I went, let me see their hands and look in their mouth. And it does cause sores in the mouth, and it is a fecal-oral transmitted illness. This is very typical looking at what the feet look like, and you often see blisters on them as well. This is ringworm, very, very common. It's not actually a worm, it's actually a fungus. It is spread by direct contact, or it also can spread indirectly by shared towels and clothing and hats and things. Interestingly enough, this can also be spread by cats and dogs, just like can't think of what I want to say. So if you see this in on a child, it can be spread by direct contact. So you want to make sure that that the child gets treatment before they are allowed to come back in the classroom. It has to be covered. If it can't, it would have to be covered. And then the next thing I want to talk about, Mary Lou and I talked a little bit about lice. Lice isn't actually an illness in terms of being caused by bacterial or a viral infection, but I thought it was something we really should go ahead and address in this training anyway, because it is spread by direct contact, and a lot of providers frequently, when they have a child that's had lice, they don't really understand exactly what they can do to help the parent sort of weather this sort of a treatment. I think doctors frequently will tell parents that they need to treat the child and that the child can come back to child care, but the extra information about needing to treat all the furniture, bedding, anything that's soft, all the toys and things at home, and the car seat doesn't get passed on to the parent. And then they often will have to deal with this in the child care agency because the child is treated, but then the eggs hatch out again, and we have a secondary case. And so it's really important to help the child care providers have the information they need to pass on to their parents about this so that we can stop the transmission. And they often will have questions, well, what about the things that we can't wash or we can't, that can't be put through the washing machine? Or the information that they need is that vacuuming helps a lot to get up the, louse, nits, and eggs that may be in the carpet or soft things. And anything that can't be washed in the washing machine could be put in a plastic bag and kept for up to a month. It takes about 17 to 27 days for the lice to hatch out. So anything that's in the dramatic play materials like hats and clothing and things that they feel like they can't wash, it would hatch out, and then without a host, it would die. So after a month, it would be okay to return these things to the dramatic player. Cytomegalovirus is an interesting virus that a lot of child care providers do not know about. Some programs have it written in their policies at the beginning of the year that they have child care providers sign a information that they've been told about this. But I find that many providers don't really understand exactly what they're signing when they do have to sign this. Cytomegalovirus is a cold type virus that usually if you get this, you have a runny nose and a sore throat and you feel like you've had a cold for a few days. And you would not think this was anything particularly to be worried about, just having a slight fever and a sore throat. But the thing about cytomegalovirus is that if about 50% of the population has been exposed to cytomegalovirus, maybe a little bit higher for child care providers who work in rooms with young children. But if there happens to be a child care provider who is pregnant and in her first trimester and she gets cytomegalovirus for the first time while she's pregnant, there is a possibility that if she doesn't have any immunity to this, that she could pass the virus on to her unborn child. And this could be a very serious situation. It can cause birth defects like developmental delay and hearing loss and even vision. It can affect the vision of the child. So it would be important if a provider was working in an infant room that she be tested, she go to her doctor and see if she has been exposed to cytomegalovirus before. If she's been exposed, there's not that much of a risk, But if she has not been exposed, it would be very wise to move her out of the infant toddler rooms where she would be required to change diapers. This is transmitted in urine and feces for months after the child has had the illness. So it would be very, very, it would be a very good thing to have this child care provider move to a different room, just maybe to a preschool room where she wouldn't have to change diapers. So that, and it's a very, from what I understand, it's a pretty easy blood test to take and to rule this out. And if she has been exposed, then there's not that much of a risk. Okay, so we're going to review how diseases are spread, and I would show this to providers and have them tell me what the four roots, what the four things that have to be in place: the source, the germs, the transmission, and the host. And then I would ask them to tell me what, how each of the routes of transmission, how that transmits infectious disease, so that I have a good understanding, or they have a good understanding of how illnesses are spread. And then I would put this up on the screen if I were doing a training, and I would say, I would ask them, first of all, do you do a daily morning health check? And I would have them tell me, well, how many people in the audience do morning health checks? And there's usually a handful of people out of a whole room that do. But for the vast majority, I still find that most child care providers are not doing this. And so what I do is I usually ask them, I say, well, what do you think you're looking for if you were to do a daily morning health check? How would you go about doing this? And I think that it's really important that we help them understand that it is their responsibility to kind of have a good idea. Are the children healthy? And they need to know what to look for. And so, I ask them to kind of throw some things out there and tell me, what is it that you're checking for? And then once we've talked a little bit about it, I try to make sure that they understand that this can be done in a very relaxed atmosphere with not, not making the parent feel ill at ease, but just telling them that, just asking simple questions like, well, how's your child feeling today? Did he eat breakfast? How did he sleep last night? And depending on the age of the child, those questions may be a little different. But what we're trying to do is we're trying to make sure that if a child is ill, that we make sure that they don't stay for the day. And this list of exclusion criteria is a very basic list. This came right from the DHS licensing rules. But remember that exclusion policies for different daycare centers may look very different because they're written by the director or the administrators of the child care agency. They have the right to add just about anything they want to an exclusion policy. But the basic minimal requirements have to follow these rules. We can't have children that have a fever, that have diarrhea that cannot be contained by a diaper, that's loose stools. We'll have parents who will say, oh, well, she has diarrhea because she's teething. Well, if we can't contain it, and that puts other children at risk. So if the child does have a diarrhea, fecal oral type illness, so they cannot stay. If they're vomiting, if they've got swollen glands or any type of a severe cough or trouble breathing, if they have any kind of eye discharge that's purulent, that's either white or yellow. Now, that's not nasal discharge, that's eye discharge, that's white or purulent. Now, any kind of rash that's undiagnosed, we don't know what's causing the rash, then that child should be excluded. And any contagious illness. And the idea behind showing the pictures of some of the illnesses there is to help providers sort of recognize some illnesses. And I'm sure that as you continue to make this training your own, you will add other pictures, things that you've seen in childcare and things that you think that providers would would be interested in seeing pictures of. But these are the basic things that all children that have any of these should be excluded. Now, I always, after I've given them that laundry list of things to look for, I always talk to providers when I do this training about there's more to whether a child can stay than just whether we see something that we know is a definite excludable disease. A child may just be not feeling well. If you see that you look for their mood, you look for changes in what the child normally, if they normally are very happy-go-lucky and they come in crying and don't want to stay for the day, and you go to take them and you feel that their little bodies are just very, very warm, it is quite okay for them to say to the parent, look, I think we ought to take his temperature, or he doesn't seem to be himself. Can you tell me, is there anything that you think could be causing his change in his demeanor today? Is he not feeling good? And then sometimes you will even have the child say, well, I threw up this morning, or mommy gave me Tylenol. There's a lot of red flags that you can pick up from just what the child says, and just having that opportunity to have that conversation sometimes will give you some more information about whether or not the child should stay. But the long and the short of it is that they need to decide, okay, are we putting the other children at risk if I let this child stay? Am I going to have to call that parent in an hour? And does it look like I'm going to be able to follow our daily routine and still be able to take care of this child? If the child is sitting over in the cozy corner crying and wants your attention or wants to be held nonstop, then you can't teach. And parents will often come, they will bring a child back after an illness and they'll say, well, he can't go outside today because he's just getting over a cold or whatever. But what we need to help providers learn to say is that if the child if he can't participate in the normal routines, then he can't stay today. Then all child care agencies are well care facilities, and if a child is too sick to go to do the normal daily routine, or if he's too sick for me to teach while I'm, while I take care of him, well, then the answer to that question about whether he can stay or not is no, that he is not well enough to attend care. Now, I get a lot of questions about, well, what about children with a thick, green, yucky nose? And so I will put this out when I'm doing this training, and I'll say, what do you think? This child he comes in, he's not showing any other symptoms, he's playing, he's happy, but he has this green, yucky nose. Well, children that, children have very small nasal passages, and they often don't blow their nose and haven't learned, to get the mucus out the way, where older children do. So very young children will often carry this green, yucky nose, and it'll be, it can be quite, just gobs and gobs of mucus. But if a child isn't showing any other symptoms, if they're able to play and I'm able to continue with my day, then the answer to this question is yes, he can stay, because he's not infectious if we're not seeing other symptoms. As long as, we're wiping the nose and we're getting our hands washed, we're probably not going to exclude this child unless there's some other reason. So exclusion, and that usually does cause a lot of discussion when we talk about that. The exclusion policies, just to kind of recap what we've said, they they do two things. They make sure that this sick child gets adequate care that we're not able to provide and still take care of the other children in child care. So, we make sure that they're home where they can get the care they need. And it protects the other children and us from getting sick and spreading the disease to other people in the agency. Okay. Let's talk just a minute about information for parents. When there is an illness that's going through the daycare center, what we need to make sure that parents, the information they get is what the early signs and symptoms of that illness is, how it's spread, and make sure how do we go about preventing that illness. What is it that we need to do? If it's an illness that requires the child to go see the doctor before they can return to care, that's information that the parent needs, and what our exclusion policy says about that illness. And this information is available at the CDC website. I often tell them that that's probably the best way to get the information that you need to pass on to parents. Okay. So you will have children who get sick during the day and need to be isolated from the other children. I know that some providers don't have the luxury of having someone who can care for a child outside of the room. So they often will say, well, there's no place for the child to go until the parent comes to pick them up. Well, the second best thing you can do if you can't remove the child from the room is to put them maybe on their cot and give them some materials to play with until the parent or guardian can pick them up. And at least get them, away from the other children and give them a place to rest, which is probably what they need most. And then, of course, anything they played with while they were there would have to be sanitized afterwards. But just making sure that they, they have a plan in place. And if they don't, maybe that's what they'll choose to be their one thing to reduce the transmission of infectious diseases, to come up with a plan of how they would handle children who become sick during the day. And then you always have to have an emergency plan, because you're going to have some children who may need care. Hopefully there's someone who will be able to meet the needs of a child if they're seriously ill. I always use this opportunity to talk about how important it is for child care providers to have first aid and CPR training, because heaven forbid you would not want to be put in a situation where you did not know what to do if there was a child that became seriously ill during the day. So if you do have a child who's sick, I have providers make sure that they understand that their information that needs to be documented is the following: any changes in their behavior, if the child has any pain, if the temperature changes, any treatment that they do, if they give the child any medicine, or if the child shows any symptoms, what time those symptoms started, and what was their response, and who was it that took care of that child, and make sure that they document what time they notified the parent as well, the child's illness, making sure that we have all that information documented. So then I would stop and do a little group activity with the providers that are attending the training. There are 3 scenarios at the bottom of this in the notes. The first scenario is a child with a rash on the arm and the back, and the parent tells them that it was due to strawberries. Would you exclude that child? Would you, how do you decide? Okay. Parent thinks it's strawberries. That is that a rash hasn't been diagnosed. No, it hasn't been diagnosed. So the answer to that would be the child does need to be excluded until we know for sure. The second one is a child that has strep and has had strep but has been out for 24 hours, but he's still whiny and cranky and unable to participate in the normal activities that that child may be excluded for. Yes, we can't continue to teach while we're taking care of the child, then the child should be at home. And the third scenario is a child with a cough that has vomited their lunch and is unable to sleep at nap time during nap. Should the child be excluded? Well, the answer there again would be yes. It's vomited, has a severe cough, so 2 reasons for him to be excluded. So just helping them, sort of understand exactly how to use their exclusion policy to talk to parents about why children should be excluded. Then I would go over the technique of hand washing with providers. We do know that hand washing is the one thing that does reduce the transmission of infectious disease over and above just about anything. It cuts diarrhea diseases by 30 to 50%, can cut respiratory infections by 21 to 45%, which is significant. So it is something that's very, very important to remember. Those are the 2 biggest killers of children worldwide. Diarrhea diseases kill a child every 30 seconds. So in other countries where sanitation isn't what it is here. So it is very, very important to teach children how to wash their hands. We do need to make sure that they don't use bar soap because that can transmit illnesses, and also not nail brushes. I've had a few providers ask me about that, but that would be another way that would transmit disease from one child to another, so we don't want to share nail brushes. So here are I would go through each one of these. I realize that you all know how to wash your hands, so I won't spend time on that. But 2 things I will point out. One, you want to make sure that they understand that they need to use a paper towel to turn off the faucets so they don't recontaminate their hands. And if they are washing after using the toilet or diapering, that the sink needs to be sanitized by sanitizing the bowl, the faucets, the handles, and the rim, all 4 components of sanitizing to make sure to kill the infectious diseases that could be left and stop the transmission of fecal-oral illness. So I would then show this and have providers talk about when they should wash their hands, like before and after they give medication or bottles or feed or prepare food or eat. Also, they should wash their hands when they come in the classroom. Frequently, I will caution providers about also if they have guests like me or the director or parents or anyone who comes in the room, if they plan to stay in the room, then they need to remind those folks that they need to wash their hands as well. Hand washing should occur always when you wear gloves, provide any kind of first aid, or help a child with a runny nose, or take out the garbage, any of those activities. Children should wash their hands when they sneeze or cough or do things that contaminate their hands. They also need to wash their hands when they come in the room and anytime they've had their diapers changed or gone to the toilet. Children should wash their hands after they eat, before and after they eat, before and after bottles, and any type of water play is suggested in the Caring for Our Children. I probably should maybe look for another picture because we don't want to encourage providers to let children drink out of water hoses, but water shared, any kind of shared water play, they should wash their hands. Then I would show this to providers, and I would have them recap exactly when they should wash their hands and when children should wash their hands, just so I know that they've gotten the basics of when hand washing should occur. This slide at the bottom has 2 activities that would be fun. One would be fun with children. You actually would take bubbles and you would blow them in the air and show how the bubbles are like germs that spread. You would sneeze and blow the bubbles. And then again, sneeze and blow the bubbles and cover them with your elbow and show a child how you're stopping the germs from getting in the air by covering your elbow. The second activity is for providers, and what you would do is you would write down the word disinfect and then have them think of a word for each of the letters in that word. For example, D for the diaper table is a place that you have to disinfect, or S is a sink, or F is a faucet, T is a toilet, that sort of thing. So there's two activities there. At the bottom of this slide, there is an activity, a beanbag activity, and how you would do the beanbag activities with children is you would have beanbags and some kind of a container like a a laundry basket, and you would have the child try to pitch the bean bags into the basket and think of a time that they should wash their hands. And there are 6 times that children should wash their hands: when they eat, after they potty, if they sneeze or cough, if they play with pets, when they come in and out of a classroom, and when they have touched a cut or sore or come in contact with any type of blood. So that's an activity for children to do with kids. Then to recap, we would come back to this slide, and I would ask providers to tell me what it is that, out of all the things that we've talked about, that they're planning to do when they go back in the classroom to change the transmission of infectious disease. And I would give them some ideas. We're talking and say, are you going to change how you do a mental health check, or are you going to teach the children to do hand washing, do the hand washing activity? What one thing do you think you might take back to the classroom? What will you focus on tomorrow? How are you going to, maybe you're going to focus on personal hygiene, or you're going to get out that yuck bucket and put the toys in it that you neglected to do that in an infant room. Or maybe you're going to discreetly work with more children about their personal poor habits. What will be the thing that you do? And then I remind them that the most important thing they can do to stop the spread of infectious disease, of course, is to wash their hands. And I often will talk about the glow germ activity. Sometimes when I do this training, I will actually do it with providers. It's a good thing to make them sort of realize what a poor job they do of washing their hands. And if I feel like they may be thinking that they do a better job than they do, I sometimes will show them things like the toilet with the black light and show them how it's not very clean. So I usually, when that black light can be really a fun thing to use with providers to show them what a job, how they do. So to kind of wrap things up, I just want to remind everybody that get your flu shots. It is flu season. And I would use this with providers, and this is what I tell them are their best places to look for information. They can call the local health department. There's always an epidemiologist or infectious disease control nurse that can answer lots of questions. They are wonderful. I've called them many, many times over the years, and they have been really, really good to get back to me and get the information I need for providers. The CDC website is there. That's also a very good place to get one-page information about particular illnesses. If you have something that's in your daycare center that you need to let parents know about. And of course, I always tell them that we are a good resource as well. For you, these are your resources, and you probably won't use this in the training when you do this with providers, but our information came from Caring for Our Children. There are lots and lots of page numbers listed at the bottoms of the slides that you'll want to check out and read the sections that go along with that information from Caring for Our Children. And then, of course, as you prepare for this training to do this training. And also there are a couple other resources that were given to every child care CCR&R that you would have these things probably on your, and they're also good resources as well. Okay. At this point, I just want to say thank you for participating in the webinar, and if anybody has questions, I'd be happy to, if you want to send those to Mary Lou, she can type them to me, and I'll do my best. Thank you. This was my first webinar, and I'm nervous, but hopefully I did okay. But just let me know. If you need information from me, my information is at the bottom of the slide right before this one. It's at the bottom of the slide, I believe. You're welcome to call me or send me an email if you, after the webinar, think of something as you plan and make changes to this presentation. Please don't hesitate to call me. Thank you.
Thank you, Karen. I know she can't hear me. I'm going to try to call her so she can hear. I'm not sure she's going to answer, but
hello?
Hey, Karen. I just thought I wanted you to hear. It in my mind, I'm just thrilled at our first webinar as a supplemental, and I want to thank you again for the great information, and your slides came across very well. I just want to remind all the participants that if you haven't done the pre-assignment for this webinar, that you need to go to the CDC website, and that's just to get you to that website. As Karen mentioned, there's lots of information that you can gain that would help you and the providers if you have some questions about infectious diseases. So just send to me what the headline is, what infectious disease headline is from that CDC. That is just my signal that you have completed that part of the requirement. And then your post assignment is, if you need that assignment, please email me and I'll resend it out to you. But it has to do, you choose only one of the options. One of them is to work with a child care provider, look at their exclusion policy, talk to them on a TTA about why you have exclusion policies, and answer any of their questions. And then just send me a copy of that TTA. Or the other option was a morning health check, and to do a TTA with a child care provider on helping them figure out how they do that morning health check in, as Karen said, very normal a way, but to gather information so that they know where that child is health-wise as they walk into the care for the day. We are going to take about a 10-minute break, and then we're going to start our second webinar at 9:40. So I will be coming back to you, and we'll start on playground safety. So stretch, get another cup of coffee, go to the potty, and we will be back in just about 10 minutes. And again, Karen, thank you.
Thank you.
Brianna, are you on?
I'm here.
Good. Did you get your PowerPoint?
I redid it.
I know you I thought, oh gosh, things like that just seem to always.
But did you not see me every time I made an edit save
Uh-huh,
that?
uh-huh, I did. So it has to be somewhere.
I know, but I even did a search on my computer by words. I wonder if it's because we were in this program. Hope you don't mind that. So you
I
guys
saw
should
that.
be
That's great.
you guys should be seeing my screen now. Um, I am going to go ahead and show you this just as a reminder. Hopefully everyone on here has their talking partner and you guys have communicated with each other to make sure, hey, let's do this via text or let's email or just give me a call. So here is this as a reminder of who your talking partner is. If for some reason you do not have a talking partner, feel free to email Mary Lou during the time when we're supposed to have a talking partner and have those conversations with her, and that will be fine. If you were already on here and you heard Mary Lou talking, I am coming down from a slight panic this morning. We had practiced this webinar last week and, made some tweaks and edits on it as we were discussing it and going through it, and then I get on this morning just to run through it one more time, and it's not there. It's an old presentation that I had from 10-step training previously, and I'm like, what happened? And I love technology. It's awesome, but every now and then it's just enough to make you crazy. So bear with me. I threw this back together again over the past 45 minutes this morning, so I hope that it is as great as I know you all expected it would be. So our goal for our training this morning is to reduce the potential of playground injuries. And our objectives, what we're going to talk about, we're breaking it down into 3 sections, is identify potential playground hazards. Now, we're not going to spend a whole lot of time discussing individual things we would look at as far as like assessment goes on a playground inspection. You guys all get that information and practice that information when we do our scales trainings. So we're barely going to touch on it, and I will show you again where you can find that information, but that was the purpose of the pre-assignment. So we're just barely going to go over that. Don't think it's going to be an hour of you having to look at pictures and assess that. We're going to talk about forming playground safety rules, how and why you do that with children, and then we're going to talk about designing a proactive supervision plan and why that's important for providers. So those are the 3 chunks of information, if you will, that we're going to talk about this morning. So first of all, playground hazards, identifying and preventing them. There are 3 types of playground injuries. There are self-injuries that happen most of the time when children are trying to show off, if you will. Hey, you guys, watch this. There's interaction injuries that happen when children roughhouse or just physically run into one another, but it's when 2 children have an accident with each other. And then there's equipment or environmental injuries. And that is what happens when children get hurt by running into equipment, jumping from equipment, or while using equipment. We are going to talk about all of these, but typically the first 2, the self-injuries and the interaction injuries, are really going to fall more under supervision in the preventative form for that. And so this first section, what we're going to focus on is going to be the equipment or the environmental injuries. And those first 2, the self and interaction, again, will fall more under the supervision that we're going to talk about a little bit later. So right now we just want to focus on this third one, which is the environmental hazards. And again, that was the purpose of your pre-assignment, where you went out either on your own or with someone else that you feel may have stellar or superior playground information knowledge, and you took the guidelines that we have in Tennessee and look for hazards on a playground. So some playground hazards, you guys, are more obvious. We look at them and, hey, you know what? It's an obvious hazard. This, it's pretty obvious there's a hazard there. I don't want to put my child in a broken swing. This is an obvious hazard. Hey, there are protective tiles that are missing. We know this is not a safe area. And this also would be an obvious hazard. I hope you know if you go onto a playground and there is a man with bulls on there, that is a safety hazard. We don't want to see that. In all seriousness, though, there are other hazards that are less obvious. And I know that this picture is upsetting and it's graphic, but this is the reason why licensing says we need to do a detailed playground inspection every day before children go on them. So you're not going to notice these razor blades on the swing set unless you are looking for hazards. And is this going to be a common occurrence? No, it's not. But unfortunately, in the world we live in today, you can never be sure or assume that your playground is safe. So these are actual photos that were taken on a playground, and then you can see where the child's hand got injured. And this could be a very bad injury. There's also things, and it's disgusting for me to even talk about, but anytime I'm talking about doing those daily playground checks that licensing requires, I always point out, here where I live in Martin, we have the University of Tennessee at Martin. And UTM has a child care on campus. So their playground is obviously outside, and it's near the walking track here on campus. During their daily playground checks, it is common, and yes, I said common, for them to find, oh yeah, sure, cigarette butts and broken beer bottles, right? How about used prophylactics? Common for them to find that on their playground. Now, not all playgrounds are going to be right around a college, but most of your playgrounds are going to be open and available for the public to get to if they really want to. So again, you never know what you can find. So it's very important for us to stress to providers the necessity of those daily playground checks and how to look for hazards that are not obvious. Okay, so we've got our obvious, yes, don't put bulls in the playground, and our less obvious, what you really have to look for on those checks. Okay, here are some things that while we may look at it as an outsider, I come onto this playground and I see this and think, oh, well, that's a hazard. But what happens to providers that are experiencing this every day in their environment is they can become desensitized to something they see, and so it doesn't register with them as a hazard. But if you see this on a playground, that is something that could easily trip the children, and actually that's metal. It could cause more injuries. So if you don't have a lot of money to repave your playground, there are some other ways that you could make this less of a potential risk for children. You can cover it. You can put something over it. You could just mark it off. If all you had were cones and you marked the area where children didn't come near it, there are ways to make this less dangerous for children. But again, if a provider is seeing this every day and they've never seen a hazard, never seen a child hurt themselves on it, they may not even be recognizing it as a hazard. Here's another example. This is my sidewalk leading to the playground. Oh yeah, I see that, but it's never caused a problem. Do you see how large of a crack that is? That will be very easy for a child who's played on this playground 100 times before to just trip one day and fall and hurt themselves, or the provider going out there. So again, if this is something I'm used to seeing, it may not register in my mind as a hazard, but it is in fact one, and something we need to help providers fix. Here's another example that's just always been there and no one's ever hurt themselves on it, so I don't see it as a hazard. But this could actually be really dangerous to a child. There are small injuries that could come to it. Yes, you could scratch yourself on it, or it could tear your clothing. But if a child were to trip and fall into that, that could actually impale them. It could poke their eye and cause some serious damage. So things like this can actually be more dangerous than what we think initially. And so providers need to be made aware if you see something like this on their playgrounds and need to take care of that. So you've got your very obvious hazards, your hazards that you really have to look for, and then there's the ones that may be there that we just need to help them find. I'm showing you guys this. There's not a whole lot for me to say about it. I just want you to take a minute and look at it. When I found this drawing online, I thought, wow, this is so wonderful, because there are some hazards that I'm used to looking for. You know why? Because they're on the safety sheet, and I go, oh, I know that I need to look for things that are not entrapment hazards. They're no more than this many inches. but it doesn't really register with me until I saw this photo and I thought, oh, that's why I'm looking for this. So for example, this right here, I never would have thought. I'm used to looking for things and say, oh, okay, I know that a child's garment can get caught on that, and that could be a strangulation hazard. But I never thought about those same hazards. Look what would happen if that was the child's hair that got caught on that. That would be potentially very painful. This right here is something that would be easy for us as adults who don't see this in our line of vision because we're taller to not even recognize that as a hazard. But if the child were to be running and looking at the person behind them that's chasing them, they could run right into that and hurt their head. Here again, the tripping hazard, a pinch hazard, something you could get your hand caught in. I just thought this was a great visual, and I wanted to include it so that you guys, when you get the PowerPoint presentation, and you will have this, you can take this picture out if you would like. You can print it out, do anything with it. I just thought it was a very good visual, and I wanted to share it with you all. All right, this right here is another document that I found online, and I thought it was just a great visual. It might be helpful for you to use with providers. I'm going to click on it just to show you where I found it online. So here it is again. You could print this off. You could print it off in black and white, do in color, and give it to providers. It was dakotafire.net. And why I thought it was so great is its layout. It's very easy to read, and it puts things on there that we don't necessarily specifically have in our Tennessee standards, like sun exposure. That's not listed. So if a provider had this, that might be something they can go, oh, check, I didn't even think about that. And I like the fact that it does have, personally, I like the fact that it does have the little check. So you can look at it and check, I've got that taken care of. One thing I do want to point out is right here where it says at least 12 inches. We know in Tennessee we're just looking for 6 inches. So if a provider were to see this and go 12 inches, I don't want them to panic. Best practice really is to have that much. We just haven't moved that far in Tennessee because we're still waiting to get people up to the 6 inches that we would like to see that would be safe. But 12 inches would be ideal. So I wanted to point that out so that individuals wouldn't see that and think, oh no, I have to have that. So you guys can also have this once you get the PowerPoint to share with providers, if you so choose to and you like it. All right, so our playground safety regulations and guidelines in Tennessee. I'm taking you again to our website. This is where you guys should have taken this sheet and done your pre-assignment, but I just wanted to show you it is on the 10starquality.org, so www.tnstarquality.org website, where you will find this playground safety sheet. This sheet, the playground information sheet, is the exact same as this sheet, which is the illustrated playground sheet. There is no difference in the, well, it's not showing it. There is no difference in the verbiage on the two of these. One just has pictures for those who are more visual. So you've got individuals who really need these pictures, and it helps them understand. And if you're one of those people, or if your provider is, great, use this sheet. I just want to point out that it's going to be several pages. So it may look more overwhelming because you're like, oh my goodness, I can't believe I've got 4 or 5 pages of this stuff. But again, it's the exact same as that first one-pager I showed you with these words. The words say the exact same thing. The only difference, and the reason this looks longer, is because it has pictures on it. I personally like the pictures. Anytime I can use a visual, it helps make sense in my mind, and it helps me show it to others. If that's the case for you, then by all means print off this illustrated one and use it. But don't be overwhelmed by the amount of information, because it's the same as the one-pager. All right, so I just wanted to show you guys that link. And now I'm going to show you a couple of pictures and see if you are able to spot the hazard using the information you have on Playground. So here, when you look at this, Do you see a hazard here? Hopefully you saw in this picture that while there is some resilient surfacing under the actual piece of climbing equipment, it does not have a fall zone that extends out the amount that it needs to. So yes, there's resilient surfacing, but do you have a fall zone that goes all the way around in 6 feet, this piece of equipment? And no, you don't. You are missing that. So that would be a hazard. Here, anybody see a hazard? Hopefully you notice in this picture that there is no resilient surfacing or protective surfacing under this equipment, which is a problem. That also means there's not going to be a fall zone, because a fall zone is the area where the protective surfacing goes around. Here, this piece of equipment, although it is made to be connected, is not. So this is 2 separate pieces of equipment. So there's going to be an equipment spacing hazard right here, because these are not far enough apart. You also have a hazard of 1, 2, 3 swings per bay here, and we don't want to see any more than 2. So there are several things that are happening here in this picture. And then one more. Do we see any issues on this picture? Again, here we've got equipment spacing issues where these pieces of equipment are only 4 feet apart and these 2 pieces of equipment are only 5 feet and 6 inches apart. In neither direction is this enough space between the pieces of equipment. So that was just a quick review of looking at some playground safety hazards. And now we're going to talk about playground safety rules. How, why, and follow through with these safety rules. All right, so establishing safety rules. When you're establishing your safety rules, there's a couple things you want to keep in mind. And the first is you want to brainstorm with your children and make this a group effort. If the children feel like they contributed to the process of creating these rules, it comes with automatic buy-in, and they're more likely to follow them than if you set them down and say, here are our rules. So during this brainstorming process, what you need to do is make sure that you take all suggestions from the children. So you let everybody, even if it's something as ridiculous as, you know, sometimes our preschoolers can come up with things, you're going to take that and you're going to write it down just like you do with any other suggestion. Now you know in your mind if we're going to keep it to 3 to 5 general rules or we're not going to have an overwhelming number, you know that what's going to happen is you're going to weed that suggestion out. But you need to do it in a way that's respectful and makes that child feel like their idea was just as good as anyone else's. So maybe when you write down what they say and you're trying to come down to your 3 to 5 rules, maybe you turn it into a voting process. So you can do a math lesson in this when you decide which rules. Or maybe you just use your adult role in saying, well, now which one would be better here, and you can kind of merge them and weed out the ones you don't need. But either way, you should take any idea. Every idea is important. And then you want to, out of all those ideas, again, keep it to 3 to 5 general rules. That's a suggestion. If you had 6 wonderful rules, by all means use 6. But try not to have too many, because any more than that really becomes overwhelming for children. And then what you also want to do is positive wording. Sometimes we tend to try and have our rules as, no, we don't do this. Don't climb up the slide. No sliding on your belly. But what we really want to do is focus on the positive. So instead of telling children what we do not want, what we need to be telling children is what we do want. And those of you who have gone through conscious discipline, that's something that Dr. Becky Bailey really stresses. What you hear and what you look for, you're going to get more of. So if you are looking for and talking about what you do want, that's the behavior you're going to get more of. Because if our rules were, don't walk up the slide, and we review, don't walk up the slide, we've got those children who sometimes only hear, walk up the slide. So again, we don't want to have rules that state what we don't want. We want all of our rules to be positive and state what we do want. So here's an example of what some of these rules might look like. If I can get my, here we go. Examples of some basic safe play rules. Take turns on playground equipment. That's positive. Play gently. That's positive. And only use equipment the way it is intended. So that is positive and could include many things which you would see on the playground all rolled up into one. So if you want your rule to be don't slide on your belly and don't climb up the slide and don't use the swings unless you're sitting on your bottom, all of those could fit into this only use equipment the way it's intended. So sometimes having a far-reaching or encompassing rule is beneficial. I found this 6 golden rules picture on the internet, and I wanted to include it because I thought it was a good example of some ideas that children may have contributed that the adult may not have thought of, but because you brainstormed with them, you thought it was important to include these rules. Because I personally would not have thought put litter in the bin or look after trees, plants, and animals. But are those wonderful rules? Absolutely. And it would be great if your children thought to do that. I really like that. And again, it wasn't something that I instinctually thought to include in my playground safety rules. But I thought that it was a very good example of thinking outside of the box, if you will. And it would be important, and especially if that's something that you had children that focused on at home, or if that was something that you were talking about your green footprint in the environment, that would be a good way to include that in your rules. So here or now we are going to try and make our first attempt at using your talking partner. So what I want you guys to do is with your talking partner, I'm going to give you 3 to 5 minutes to get together, and as a group, I want you, or as a dyad, I want you to come up with one example of a basic playground safety rule that you would have if you were teaching a preschool classroom. So you guys get together and try to come up with one, and remember that we want to use positive wording. And then when you come up with this rule, okay, Mary Lou.
Go to that sidebar. It will bring it up. Like right here. Click on that.
Okay, sorry. I panicked for a moment. On your screen, you see text 781016 and your message to this number.
Brianna, the two the 2 is 37607.
Yes, that's fixing to say. So you are going to text, just like you're texting somebody's phone number, 37607. So that's the phone number that you want to send your message to. So you're sending your message to 37607. In the message box, you want to put this first number, 781016, and then whatever the rule is that your group decides. And then once you send it, it will appear here on our screen.
And Brianna, I've had a couple emails, people concerned about how do they go to the email, to their email when they're on the webinar. Just go to your email and just stay on the webinar. I mean, you just click on your email box and email back and forth if that's the way you've decided to communicate with each other. And if you accidentally click out of the webinar, just go back to your invitation and just come back on through that way. But if you have problems, anything happens, just text me or email me and I will walk you through it. So have fun talking.
All right, we're going to take about 2 more minutes if you guys can start sending your suggestions to that number. All right, we're getting some good suggestions here. Know your boundaries. Have fun. Oh, I do like that one. Go up the stairs and down the slide. Sand stays in the sandbox. Watch for others when you run. A couple of these, know your boundaries and run with caution, those are really good vocabulary lessons. So again, if you are creating these rules and you're brainstorming with your children and they understand these words, or you're introducing these words and you're making sure they know what they mean, that's a great lesson in and of itself. Enjoy the day. I like that one too. That's great. Everyone so far has done a great job of making sure to use the positive wording. This go up the stairs and down the slide was a good one, because that's one that trips providers up a lot of times. They want to say, don't climb up the slide. Safe steps with your feet. That's good. And that could be another one that's a far-reaching rule. So safe steps with your feet could mean lots of different things depending on what you need it to. It can talk about how you climb up the ladder safely, how you don't climb up the slide. That could be a very good one. All right. You guys did great with that. Hey, Mary Lou, how many groups did we have?
I don't remember.
Oh, I like that. When you see something, where is you? Okay, I just didn't want to go on if we still had some coming in. We stay with our class. That's good. I really like the when you see something worries you, tell an adult, because a lot of times we get so busy trying to teach children to handle things yourself, which we certainly want our children to become socially competent and do that, but an unintended consequence of that oftentimes is we get too busy into the tattling, don't come tell me everything, that children sometimes think they can't come tell us something, and we want them to know that the adults are there to help protect them. So I like that. If you're worried about it, tell an adult. All right, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So that's probably everyone. All right, very good. Thank you guys for participating in that. All right, so a follow-up to these rules. So now we have our rules established. We brainstormed with the group. We came up with 3 to 6 maybe general rules we're going to follow. So now what do we do with those? Now we know that licensing tells us we have to have these playground safety rules posted on the playground. So great. We made them, we posted them on our playground. But what's even above and beyond that when it comes to best practice for these rules is you need to follow up with those. So certainly if this is the beginning of your year with these children, you've just created those rules, they're new, and we need to review those every day, at least for a few weeks, to make sure that everybody understands them, recognizes them, and knows what they mean. But even after that, instead of just making them and setting them aside, it needs to be a continual process of renewal for going over these rules. So even after they've been in your classroom for 9 months and you know that they know these rules, we need to continue to review them at least twice a week. Now, a recommendation for when to review them. Monday mornings are always a good time for review. Why? Everybody forgets everything on Monday morning. We've had a break. We haven't been there over the weekend, so it's a good time to review. So before we go outside, hey, let's go over our playground safety rules real quick. Then maybe another suggestion would be Thursday, because it's been a few days since you reviewed, so it's a good time to do it again. Now, you can do this indoors before you go outside, or you can wait until you're out there and maybe you wanted them to see the posted rules on the playground. I personally think it's a good idea to have your playground safety rules written indoors and outdoors, so you can review them and then go outside, and there you have the visual reminder outdoors as well. All right. So action steps. What happens when these rules have been broken? Well, the first thing you can do, remember again, they're posted outside, so you're going to verbally and maybe even visually review that rule with the children. So we had I can't remember what it was, use caution with your steps. So, you were walking up the slide. Let's go over here. Were you using caution with your steps? No? Okay, so there's your reminder. Then I have creative redirection on here, and I have this picture over here for a purpose because I was using it as an example here. Let's say you've got a child who is doing something he shouldn't be doing. So Johnny just won't stop bugging Mia. Well, let's say Johnny loves to rake, and that's what he wants to do when he's outside. Well, if he won't stop bugging Mia, he's not going to get to rake today. Okay? Or let's say that Johnny absolutely loathes raking. He does not want to rake. Well, you know what happens every time he bugs Mia? He's got to go over there and rake the mulch. So depending on what that child prefers, you might have to get creative with some of that redirection. And I put the picture and used raking as an example because I try to tell providers often, if you have that out there for the children, you know raking the mulch is something we need to be doing anyway to help keep its protective surfacing, what is the word I'm looking for? Oh my goodness, the word completely left me. But we need to rake it and keep it fresh so it doesn't become compacted and properties and loses some of its resilient properties. So the more you rake it, the better it is for the mulch. So if you let the children do that, it's helpful for you. They become helpers, and a lot of times they enjoy doing it. All right, so the final action step, and this should be used only as a last resort, is the separation of the children. And that may mean that you've got two children who need to take a break from playing with each other. So, you know, one of you play over here in the ball area and one of you come over here in the swinging. Or that may mean, okay, you've got to come have a separation from everyone and you need to have a 3-minute cool down period. But whatever it is, that should be the last resort. You should try and come up with these other things that will be helpful before that, because we don't ever want children to lose their outdoor playtime. All right, so those are safety rules, how to create them, what we do with them, and now we're going to talk about proactive supervision. And this is going to be the focus of that post assignment that Mary Lou has already sent out and referred to once this morning. So proactive supervision, what is it? First, let's talk about what it is not. This, taking a nap on the bench, is not proactive supervision. It would be inadequate. Some other examples. Reading is not active supervision unless you're reading to children. We should not say sitting unless you're sitting to comfort a child. Playground time or gross motor time is not the time for supervision or supervisors to be taking a break. It's not a time to hang out or socialize. And it's not a time for yelling. We shouldn't see yelling on a playground except as a last resort for injury prevention. So you are too far away to reach this child and you see something that they're doing that's not safe, that should be the only time you yell. stop, Johnny, you're going to slide. Not as a, get down, don't do that, stop this. That is not active supervision. All right, active supervision means we're going to be changing locations often, so we're not sitting on a bench and posting ourselves there. Also, what you should consider is moving in a random pattern. So you've got these areas that you're going back and forth. Well, don't let the children figure out, hey, I've got 5 minutes before she comes back over here, because she always makes this same circle. Move in a random pattern, and it helps make sure or ensure that you're going to see everything you need to. Also, active supervision includes interacting with the children. Talk to them, play with them, answer their questions. While you're doing that, make sure that you don't take your supervision off of other things. I have some statistics that I included in the notes section of this slide that goes with this 40%. So you're thinking that's random over there. I'm not going to cover all of them, but I am going to give you just a couple of statistics. And I wanted you to have them all because you may pick out different ones that are more meaningful to you when you're talking with providers. Each year, 15 children under the age of 14 die from playground-related injuries. And each year, more than 200,000 children under the age of 14 are treated in emergency rooms for playground-related injuries. Of those 200,000, lack of supervision is associated with 40%. So 40% of those injuries could have been prevented with appropriate supervision. That's a huge number. Okay, some other stats I wanted to share, and I even put the site where this came from, which is the National Program for Playground Safety. This was a study that came out in 2009. Of reported injuries, 67% involve falls or equipment failure. 7% are collisions with children or equipment. 7% are from entrapment hazards, and 11% are other. This also I thought was very good information. The top 4 pieces of equipment associated with injuries are climbers, swings, slides, and overhead ladders. Now, surprisingly to me, overhead ladders were only 9%, which would be like your monkey bars. I would have thought that would have been higher, but actually climbers are 23% of injuries, swings are 22% of injuries, and slides are 17% of injuries. So I thought that was interesting. Oh, another interesting fact, 40 deaths between 2001 and 2008 happened on the playground, and the median age for those children was 4 years old, which is heartbreaking. 27 of those deaths were a result of hanging or asphyxiation, and 7 were related to head or neck injuries. And that is so tragic. So we want to make sure that we can prevent those as much as possible, and active supervision is a great way to do that. Oh, 40%, I made it big. Okay. So, proactive supervision on the playground, it's also when children are outside involved in gross motor, it's a perfect opportunity to assess these children's developmental levels. Now, we automatically think, oh yes, it's a great time for gross motor observation, and it is, but there's so much other learning that takes place when children are outside that providers can open their eyes and be aware of as well. I have included in here a link to a video, and I want you guys to watch this video of some children playing, and I want you to know that I'm going to have you use your talking partner again in just a minute and see how you can relate this video of children on the playground to the 10Ls. Okay, so I want you to pay attention when we're watching this and know that's what it is you're going to be looking for.
Whoa, yeah, you're sliding right down. There you go. Just look around and wait. Look around, wait. Yes, Will. Come, Mikey. What? Nice. Good thing. No. Just come down, go through, yeah.
Okay, so I do apologize for that video. I was telling Mary Lou when we first came on, I had a wonderful clip that I had found from YouTube. It was of much younger children, and it had better sound where you could actually hear the children talking on this, and we didn't have that. But I could not find it again this morning when I was recreating this PowerPoint. So we got the video we did. So if you will, in your mind, just make those children a little bit younger. I know that the oldest two were obviously school-age children, but we are going to look at the developmental standards. So in your mind, if you will just make them younger. One thing I did learn from that video was that obviously in Australia, you send children to a public playground, one in their church clothes and two barefoot. So aside from those, looking at these 10ELDs, so these are the 4-year-old standards, and I just pulled out these, sensory motor, gross motor, fine motor, and personal health and safety. Think about these and what you just observed in the video and see how you can link those two or what you can assess about the children we just observed. Talk about it with your talking partner. And then, again, want to have you respond via this poll anywhere with what your thoughts are. So using that section of the 10ELDs as a guide, or others if you have them with you and notice something. I didn't want to limit you. I just was giving you these as an example. Want to have you see what you determine about the physical development of these children and message that here. So send your message to 37607 and be sure to include the number 24724 and then your message. Okay? Take about 5 minutes with your talking partner and see what you guys can come up with.
Brianna, I'm not quite sure what I'm supposed to be thinking about. So as I watched that video, they were older. But what you're wanting us to look at are the 4-year-old 10ELDs. And like the one girl was, I mean, she was climbing all over everything.
Right, right. So I would know looking at these.
Like develop body strength, balance, flexibility.
Yes.
Okay.
Or explore a variety of equipment and activities.
Okay.
We are seeing that she obviously has that skill met. Does that make sense?
It does.
I'm going to show this one again so you can write down the numbers. So again, you're sending your message to the number 37607. If you want to write that down, and then you want to put H24724 in the front of your message. So I'm showing you those numbers, but then I'm going to come back to the 10Ls so you guys can look at that while you're talking with your partner. I'll leave this slide up. See, does that help?
Yes, I think so. Except at the end, you may want to put the numbers back up in a little bit.
Okay. So take 3 to 5 minutes. I'll leave these up, and I'll pull the numbers back up momentarily for you to send your message to. Okay, I'm going to give you 1 more minute looking at the 10L screen, and then I'm going to switch back to the numbers. I do agree with the girls needed to review the safety rules using equipment as intended. I thought it was funny that the father said, "Oh yeah, bigger girls do whatever you want to, be monkeys, but my little favorite princess is not allowed to climb on top of that tunnel." I'm teasing. I know that she was younger and may not be able to do that. Oh, I like the playing without shoes, able to feel textures, relating that to sensory motor. That is true. Balancing on the bike, yes. Coordinating upper and lower body together. Performing complex tasks, yes. So we can see lots of things that happen on the playground. Again, I wish I could have found the other clip because there was more conversation happening with the children, them talking to each other and singing together. But when you're doing this, if you want to look, if you've got more than 5 minutes to find the video, like I was trying to throw together this morning, you may be able to find one that is more appropriate, certainly with the correct ages of children, or you may have a video of your own children playing that you could use also. Spatial awareness, balance. All right, 1, 2, 3, 4, 5, 6, 7, 8. All right, very good. So now the last thing we're going to talk about is a playground safety plan. So this is different than the safety rules. The safety rules are something that you establish, you create with the children and talk about with the children. But a playground safety plan is a step above that. It's something that the provider has in place to help ensure safety. And this should always include something we're going to refer to as zone defense. All right, so when we're talking about zone defense, zoning is going to include the zoning of where the caregivers are. So where have they positioned themselves and where are they moving to make sure they can see everything. And also zoning types of play. So looking at this picture, is in front of the swings the best place for ball play to occur? No, we know the answer to that is of course not. But sometimes outdoor play is seen as a free-for-all. I'm going to use that for lack of a better term. And children are just allowed to run around and kind of do whatever they want. But when we talk about zoning, we need to zone appropriate areas for different types of play to take place so we can prevent injuries. So we want to have a designated zone or play area for ball play, so we can make sure that those children can successfully carry out the type of play they want, whether it's kickball or just tossing the ball, whatever it is, where they have enough space and where they're not going to run the potential to get kicked by a child swinging, to get hit by a child coming down a slide, or to collide with a child who is using a riding toy. So ball play needs to have its own designated space. I just mentioned riding toys. They should have their own designated space. Sometimes providers are fortunate enough to actually have a track like a sidewalk, or they've created a riding track area. That's awesome, but some providers don't have the luxury of being able to afford that, and so you can create a riding track in different ways. You can do it with chalk. Here's your riding track. You can do it with tape. You can do it with paint. You just need to designate a place where you can safely use your riding toy, and you will be able to do that play without interfering with someone else's play or having your play interrupted. So we need ball play, riding toy area. We also need a zone for less active play or alone space. So if you've got a sand table where a child can go if they kind of want something quieter or calmer, they need to know that they have that protected zone to be in as well. Swinging certainly needs to have its own large play zone. So nothing else should happen in the swinging zone ever, because when a child is swinging, they do not have the option to stop when if someone were to dart in front of them. So no other play should happen in the swinging zone. You also need to have a sliding zone and a climbing zone so that when children are carrying out that type of play, they're safe in that area and they don't run the risk of colliding with someone else. So when you think about setting up outdoor play areas, providers need to have in mind zones for where the type of play occurs, kind of like they do inside the classroom when they're setting up centers. You want to carry that mindset outside as well. But additionally, we want to have the zones for where the caregivers place themselves. So the zones in this picture, we have here zone 1, where this caregiver is, and then we've got zone 2 over here where this one is. Is that sufficient for this picture? Certainly if we've got these caregivers that are moving, because remember, you're going to have your zone where you know you need to be stationed, but you're going to move around within that zone to make sure that you come up here in the front and you walk around to the back so you can see everything. That will be great. Ideally, if we happen to have a third adult, we could place them over here in front of where this yellow tunnel slide in the stairs is. That would be great to make sure that we always have someone stationed there, but we don't always have the luxury of having that extra caregiver. Which leads me to this point. How can we zone where the caregiver is if there's just one caregiver? So if you only have one caregiver, that makes the other portions of this supervision that we've already talked about all the more important. That's all the more reason to make sure that we've got our play areas in zones so that children know, hey, If I'm riding on my riding toy, I need to stay over here. If I'm playing with my balls, I need to be in the ball play area, because that provider is going to have to be on her own, on his or her own, moving around that play area and making sure they can see all the children. So her moving around or him moving around and making sure that I have just come over here and I've seen the ball play. Now I'm going to check the riding area. Now I'm checking the slides. I want to look at the swings. They are going to have to know mentally that they're checking each one of the zones. So it's going to have to become the intuition of the caregiver to make sure that she is being proactive the entire time on the playground and moving to check all the areas. But again, if you include with your safety rules that you review with the children, maybe you include those zones in your safety rules, because you're going to have the children who then themselves are going to help you ensure that these safety rules are being followed. Because you better believe when you've got a rule that's broken, those other children are going to be there to remind the one who broke the rule, whether you're over there or not, that they need to be doing what they need to be doing. So in that case, your rules and your other children are going to help you also ensure the safety of the outdoor playtime. Okay, so I put this one on here just to see how comfortable you feel, or if you have questions, or if you've ever had a question come from a provider about how do I position myself, how do I use this zone defense when I'm on the playground. So just going to give you a minute or two. You don't have to discuss this with your partner. You can if you would like, but if you have any questions about this zone defense, I want you to be able to ask that. So you can do it by sending that question here to this number if you've got those. And I'll just give you a minute or two to get those sent in. And that question can be about creating the zones for the children, or how to position the zoning of an adult, either one. Sorry about that. All right, so I don't think we've got any questions coming in. If you do have a question that you did not submit, oh, here's one. So should children not be allowed to play in a particular zone with one teacher? No is my initial response. That's not what I'm saying. And I'm trying to think of what that may mean. Are we thinking like if there is a climber or a more dangerous zone, then we wouldn't want children to be in it? And no, again, we just want to make sure that the children understand and are respectful of safety rules, and that the caregiver can make sure that she's moving around to always be able to see children in those areas. So if you've got one caregiver who's moving around to make sure that she can see all the children on the playground, what that means is if you do have one area that is potentially more dangerous, so you do have a climber and then you've got a riding toy area, a ball area, and a swing area, it may mean that you're coming to that climber area after every other zone. So ball check, climber check, then swing check, back to my climber check, then my sand check, back to my climber check. Does that make sense? So you will be going back and checking that area more frequently as it carries the greater risk. But we don't want to say to children, you can't play here until I can get a second caregiver out here, because then children are never going to be in that area. And for that matter, if you've got something that's so dangerous that a caregiver always needs to be there, perhaps we need to rethink whether or not we have that on the playground. And with that being said, one of the very first things I meant to address, and I even told Mary Lou that I wanted to be sure and say this, and I forgot, is the first thing to consider with supervision and an outdoor playground area is to make sure that the equipment you have on this playground is developmentally appropriate for the age of the children that will be using the playground. It needs to be challenging, and yet it needs to be safe. So if it's a playground for toddlers, you're not going to have the same equipment, the big climbers with the monkey bars, that you would have for your school-agers or your older preschool children. There really is a difference in the type of equipment that's going to be on the playground. Playgrounds are not one size fits all. That in itself is a huge preventative of reducing the risk of playground injuries. So make sure the equipment is age appropriate, which makes me think that may be what this question is asking. So if your toddlers are on a school-age playground, then certainly there are going to be areas they should not play with, and I would recommend trying to come up with a different play area for them. And I hope that answered that question. What I was in the process of saying is if you do have another question that comes up, feel free to contact me. You can email me, give me a call, whatever you're more comfortable with, and I will get back to you as quickly as I can. But that is the presentation of playground safety and supervision. And now for your post assignment, what we want to see you guys do is, with a provider, create a playground safety plan for that caregiver and her playground, which is going to include those zone defense strategies. And we want to have you send that to Mary Lou. And Mary Lou, what was the date you said, October?
The end of October, October 20, well, if you just have it before Halloween.
All right, so make sure that you get with the provider and you can help them come up with a playground safety plan and get that to Mary Lou before Halloween. And if you're working with this provider and you're like, oh, I got this, and you get out there and you start creating it and then you have questions, let me know. Send me pictures if you want and say, hey, what do you think of this? I'll be more than happy to help you with that. Don't feel like you can't ever ask questions. I hope that was helpful for you guys. That was the end of the presentation, so I am going to turn this back over to Mary Lou.
Well, I again thank you for putting together this second webinar. We have finished our first health and safety webinars for September. As I told you, I will be sending out the link for next week's two supplementals, which is environmental health, which will be led by Ashley Holman, and child health policies, which will be led by Karen Wright. And as Brianna said, if you have questions, please feel free to contact me. But I hope you all have had a good learning experience this morning. Any feedback you can give me, I'd appreciate it. So, oh, and then just a reminder that tomorrow at 9 o'clock Central Time, we'll have our first professional development seminar, and I'll be talking about Telling 8 training. So if you can join me tomorrow, please do. Have a great rest of your Monday.